we enter the moment of discussion. So, Maciej, Barbara, I'm counting on you for this one too. Let's see, and on the audience, of course, you have this function in your Zoom app for sending written requests. So
Yes.
if it's with you, Barbara, and Maciej, I will start by reading the questions that we have so far.
Yes.
So Maciej has answered one question regarding CSC. He's been asked what would be the algorithm of decisions after treating CSC. Well, he kind of answered it a little bit during his talk, but basically the second part of the question, maybe the one he hasn't addressed that much, is how soon would you retreat and how many tries will you give it? Talking about CSCR. If you want, Maciej, please, to develop on the answer.
Sure. So I would check the patient in 6 weeks after each session. Let's say that after first session, I see no response at 6 weeks, then I repeat the next laser. However, if there is a tendency for the subretinal fluid to diminish, then I will wait for the next 6 weeks. So I will follow up patient. I will see the patient at 3 months. But altogether, I think I would try the laser 3 times before switching to another treatment modality like PDT, for example. But I would like to also say, sorry, about one thing that one important quality of the laser that is also has some anti-neurodegenerative action. So, for example, when we have the shortage of Visudyne, I control this patient with laser, and they do not deteriorate their vision because it works well for the RPE function. I believe that.
All right, good point. So you will give 3 tries. And could you elaborate a little more? What do you mean with tendency to improvement? You have like any more objective data, like 20% fluid reduction, something like that?
Well, I would say that if the reduction is close to 50%, that I would wait. If it's smaller, then it's rather unresponsive case.
Excellent. Thank you. I cut you before, Barbara. Sorry.
So since I started, initially I was afraid because I think we all were, because we didn't know what we might encounter by retreating the patient. But I observed that even retreating a central serous chororetinopathy case on a monthly basis, when there is still fluid, it fastens the recovery and it gives no harm. And I usually pass over the macula as well, especially if I have small foveal bubbles. They are very central. Only if I keep those parameters that I have shown offered by the company, it fastens the recovery. So I actually think that the interval should be shortened. That's my theory. And excellent. I think there is a question for me.
There's one for you, yes? If you
sorry.
Regarding the use for subthreshold laser for that subretinal fluid that we can see in dull maculopathy, high myopes. Do you have any experience on that?
No, I missed the question. I'm sorry.
It's in for some reason. Oh, it's in the section of answer question because Maciej.
Yeah, I'm checking them.
Maciej is reporting 50% success.
Yes. Because these patients are really a problem, right? Because
there are no
recommendations for treatment, and I think MicroPulse laser works in some cases. So at least we have something to offer to our patients. So I'm trying for that entity.
All right, and then please, Barbara, have you ever tried in one of these cases?
But I didn't get which one
for the subretinal fluid that you find on dull maculopathy.
Yeah, that's what I mentioned in my, I tried in at least 5 patients, and I had very disappointing result because I observed many relapses. And but the fluid in that condition goes up and down, even spontaneously, very frequently, and very in a short period of time. So it is not possible to say whether it is the laser doing something or if it might spontaneously improve. So far, I do not offer any recommendation for tilted disc syndrome or dome-shaped linked subretinal fluid.
All right,
unfortunately.
So let's see for some of the unanswered questions.
Well, there is a question, I think it's offered to me. You showed a couple of cases with good but transient response. Do you believe that it to be caused because the laser does not address the optimal cause? Yes, as I said, I can confirm that the laser is symptomatic. So if you have a subretinal fluid, you might be able to reabsorb it with the laser, but if you do not address the cause, like in optic pit, you have to seal the pit. If you have traction, like in MTM, you have to treat the traction. But the laser can be seen as a way to delay surgery. There can be cases where you don't want to do surgery right away, and the laser is a good option.
Right, it's very important to remember that not to avoid the temptation to consider laser such a like a magical solution.
Yeah.
Anything
Yeah.
it helps reset the RPE, but when the problem is beyond the RPE, you will mostly get a temporary solution.
Yeah.
So don't expect it to be solution for everything.
In real life, see, I have the laser in my office, and I see at the laser as a very good way to try and treat the patient, at least when they have subretinal fluid or intraretinal fluid, without giving harm. If I keep these parameters, that's very important, because we need to keep the safe parameters. So I always try the laser first, and then I do something else if it doesn't work, or I combine the treatment. Somebody is asking why I treated only on a yearly basis, one treatment per year, because those were cases where they were very peculiar. First of all, sometimes, you know, in real life, the patient cannot be able to come back faster to the follow-ups, or just because I was observing the potential of the laser in reabsorbing the fluid, maybe not just 1 month later, but a few months later. So I did not have a schematic protocol to follow. I was judging case by case.
Excellent. All right. Another question, is there any difference in results between the 577 810 nanometer wavelengths? Well, so far, most of the manufacturers are producing their machines toward that 577, which is the yellow. There is, I have never worked with 810 with the infrared. There is some research on it, comparing infrared with green and yellow wavelengths. And it seems to be that when regarding subthreshold, is you using the correct parameters, there doesn't seem to be any difference. But as I mentioned, I have no experience on this. It's just what I know about the present literature. So well, definitely it should work.
Because I'm using both, in fact. Right. And you know what works sometimes is switch from one to another. That's what I can say. But I wouldn't say that any of these wavelengths is better, because in both cases we target retinal pigment epithelium, right? So it's similar. It's a question of adjusting the parameters.
Good point. Thanks a lot. So
there is another question.
You want to go for the last one?
AMD treatment. What about combining anti-VEGF and laser for AMD? Well, I decided to leave out these cases because they are very controversial, and we need, I would say, I think a very large group to be able to say something about this kind of treatment. But I can say that I did. I applied the laser to AMD patient with subretinal fluid, and I think it is a good way to enlarge the interval between injection, but I don't want to make any statement because we need a large number of patients to be able to say that. It's too difficult to collect the data and I cannot do it alone. So I can only give you my experience.
Yeah, thanks. Yeah, indeed, there's no evidence no strong evidence regarding that. If you ask me, I'd say that the kind of inflammation, the kind of physiopathological process that you have in AMD has not much to see with the way subthreshold laser works, but we do not definitely know how AMD works, so perhaps it might be of help.
I think it makes sense to try, because as long as we do no harm and as long as we have proven that the subretinal fluid can be treated, it makes sense to do it as well.
Yeah, as long as you know what you're doing, means that you deliver laser with no harm, and as long as you not pay the injections, there's no problem with that. I mean, I see no problem with that.
There is one paper on a so-called resensitization of retinal tissue in AMD. So this was a case when the laser was applied after tolerance to one of anti-VEGF drugs. So it was applied, and then the same drug worked again. So it to some extent explains this theory of better function of the cells after application of subthreshold micropulse.
Interesting.
Yeah, that's
just
right. I mean, we know that in AMD, on the long term, you have a failure of RPE, of the pump function of the RPE. So maybe not all fluid that you can see there comes from the neovascular membrane. Some might come from this failure of the RPE, which would be a CSC-like scenario. So part of the fluid would respond to subthreshold laser and part of it to anti-VEGF agents.
Yeah, it's possible.
All right. So one more question. I am also having trouble with central large foveal cysts not responsive to anti-VEGF. Can we use micropulse? Well, I think we all having problem with that kind of cysts. And as Barbara said more than once, you absolutely can. I mean, you will do no harm if you know what you are doing, and it might be of assistance, of course. But sometimes these large cysts are more structural than anti-inflammatory, and they simply do not respond to anything.
All right. I think it's been an interesting session. I think it's really a technology that needs more and more data. If any of you or if any of you are using it, we would be, happy to collect the data and know more about it, because it's a wonderful technology. It's an easy way to treat some patient, to improve their status, and without offering any complication if we stick to the protocol and to the program. And so I think it's very important to know more about it, right?
Exactly. So I think we have time for one last question at least. We are being asked if does anyone have experience with subthreshold laser in chronic diabetic macular edema? Basie, do you want to take this on? Since Stella is not here, it was her topic.
Yeah, so chronic macular edema, but in which clinical entity? In general?
Diabetes.
Diabetic, sorry.
Diabetic. Well, I think we should apply the same rationale as with the other diseases, that it surely helps. There are different approaches to diabetic macular edema and application of subthreshold laser, because some of the researchers take into consideration the amount of edema. And as we know from some research, the 400 micrometers is supposed to be the border of effectiveness. However, other researchers take into considerations the visual acuity. So in both ways, I think it works with very high let's say, edemas with, for example, very large cysts, I think it's quite hard to get to the RPE. So maybe 8-10 laser works better, but I think that generally the results are poor. But if the elevation of the DME is not that high, I think it's worth trying. It's worth switching to MicroPulse.
Wonderful, thank you. All right, I don't know where are we exactly in our respective schedule. We have no questions so far.
No question, and maybe no more time. It's been I think we should wrap up.
Very well. I'd like to thank all the assistants, the panel, of course, and Lumibird again for sponsoring this event. Remember, please, all the assistants at solslasersociety.com. You have available a lot of formative and educational resources for you to get yourself into this world. Thanks a lot for your assistance.
Thank you. And thank you, Jeannie and Kenny.